Jay Gunkelman has been involved in this field for, I'm sure, half century or more, but since the 70s has specialised in classical clinical EEG and is one of our most experienced EEG and QEEG specialists in the world. And a number of us are currently meeting regularly in a QEEG mentoring group with Jay, and every day there is so much to learn. Jay's the author of many scientific papers and presentations, and contributes to a mounting list of books. He has a depth of understanding and breadth of mind-brain function that is mesmerizing and terrifying and fabulous, and yeah, we all very much appreciate it. So Jay is going to be talking to us today about treating long COVID, understanding long COVID and its broad range of presentations across multiple systems of brain body. And so we look forward to your presentation, Jay. You've been made co-host, so you should be able to share your presentation, and we look forward to hearing what you have to share.
Thanks for the introduction. I always blush at those things, and halfway prefer not to even hear them. But thank you. You're supposed to give conflicts of interest. I'm retired from my company. I don't know that that's much of a conflict anymore. I'm not soliciting business, for goodness sakes. I'm old, I'm retired. So don't pick on me. I'm busy enough in retirement. But the more important thing on this screen is something that the APA requires on presenter screens, and that's basically a warning to take good care to know what your licensure allows you to do as a professional. Some of what I'm describing is ischemia and working with people who have long COVID. It's a medical application working with that. Some people will end up challenging you if you're working on that area with the client. You should be able to, because you're optimizing brain function, you're not injecting something and so forth. But again, it's entirely up to you to know what your local, all of these professions are regulated locally. So know what the boundary is for your practice. And I'm going to describe things from my perspective, and some of it may fall within, some of it may be discussion of medication, for instance, which may be outside of your particular licensure. Just be aware, I'm going to describe all of this without respect to whether it's within somebody's license or not. To start with, we're looking at between a third and a half of the people that have had COVID have long-term symptoms. Now, there's a formal diagnosis recently, a consensus agreement as to what long COVID would be. They don't know what it is, but they know that you have to have it for 2 months or more after your recovery from the acute effects of COVID. But there are some people who don't end up with any kind of a severe COVID. They don't get hospitalized. They have a little mild cold symptom. Some people are relatively asymptomatic, and later they can come up with these long COVID symptoms of brain fog, confusion, fuzzy vision, postural orthostatic tachycardia syndrome, where you stand up and get dizzy because your heart gets really fast. And it's inefficient at pumping blood at that point. So there's an agreement that you have to have it for 2 months after you've recovered, but some people don't have an obvious symptom and they just end up with the long COVID symptoms. So I'm not worried about the diagnosis of it. People will present with this, and it's up to the medical doctors to make a formal diagnosis on this, but they'll present with the brain fog to a practice for a psychologist or a counselor, or a psychiatrist, or a medical professional. So in the United States, and I've given this talk before, in September, there were 33 million people that had recovered. Obviously, we've not done a very good job containing the infection over here. We're kind of a lesson in how not to do it, but nevertheless, that gives us, just in the United States, about 10 million people that have long COVID symptoms. And if you think about it worldwide, this is a gigantic market that doesn't know who we are, they don't know what we do, and they don't know that they should be coming to us for help. So let's us at least learn what it is that they have and how it is that we can address that, and actually look at some evidence pre and post treatment with COVID. So a little bit of background about COVID itself. There's a spike protein, which all of these vaccines are targeting. That spike grabs onto ACE2 receptors, angiotensin converting enzyme 2. It's widespread throughout the body. So this infection can grab onto you in lots of locations. It's most common in the nose and mouth, where people lose the sense of smell or taste as an initial symptom, but some don't have that at all. Some just have a gastrointestinal, like an upset gastrointestinal system, diarrhea, and so forth. Some people end up with it in their eyes. Some have just direct cardiac infection. It's not unusual to end up with myocarditis, and the heart itself can end up being damaged rather dramatically. There's actually a study about it in athletes I'll quote in a little bit. Liver and kidney aren't as easy to get to directly, but they can become infected. And then obviously for us, the concern is quite often more oriented towards brain disturbances. So ACE2 can actually grab onto endothelial or internal cells, visceral cells, not outside skin, but endothelium, and also the smooth muscle on the inside of blood vessels. So that's one of the spots that they can grab on, because we've got the ACE2 protein there. A lot of people didn't think we had any in the brain, but we do find that ACE2 is expressed in the brain in glial cells. So on rare occasion, you can have direct COVID brain where the COVID infection is in the brain. It's not that common. More often, you've got lung or GI or something peripheral, but you can end up with a direct infection in the brain. The glial cells have ACE2 receptors, and as such, you can have a direct infection. How does it get there? Well, this loss of sense of smell is quite often just the loss of the sensor, and it doesn't go through the cribriform plate and up into the brain. On occasion, it does. The olfactory bulb can be the point of entry because of an infection through the sinuses. You can get a normal viral infection of the brain through the same method, a severe viral infection in the sinuses going through the cribriform plate and up into the olfactory bulb area and into the brain. It can come through the eyes. I mean, the eyes have receptors for COVID, and if they're infected, you can end up with it coming through the optic nerve and into the brain. More commonly is a vascular entry. The blood vessels, you can have microemboli with COVID actually in it that comes in and creates a larger embolism and a stroke, but that's a vascular entry into the brain. But not everything comes into the brain. You can have a generalized effect that influences the brain. If your lungs aren't working and your oxygen level drops precipitously, you can actually have hypoxia, and that hypoxia can negatively impact the brain. In fact, hypoxia creates edema in the brain. And you can have direct inflammation, the cytokine storm that they talk about when the infection is at its peak and the body's got a gigantic immune response. Well, that immune inflammation in the brain can also cause ischemia, and inflammation. So they looked at inpatients, and inpatients aren't the same as outpatients. These were people that had been in ICU, and 82% of the people that were in ICU that were inpatients ended up with neurological manifestations of some sort. That included, for some, an encephalopathy. And here, they're not talking about something mild. The worst was coma, alpha coma. But some, when they're extubated, they're taking the intubation out, they had confusion and weren't cognitively intact. Some complained of dizziness. It was very common, as you see, 10–15% of them also had disturbed taste or smell. And people that aren't even hospitalized quite often have disordered taste and smell. If you've lost the sense of smell and taste totally, don't wish for it to come back quite so hard. People who get it back usually have very distorted senses of smell and taste, and it's not good. They don't complain of smelling roses when they come back. Things stink bad, and you have to retrain the sense of smell. There are techniques to do that, but when the sense of taste and smell come back, it's not always smelling roses. Athletes, 15% of the college level athletes that had fully recovered from COVID in a study at Ohio State, they had MRI evidence of heart muscle damage. You should avoid getting this, because even though you look like you're fully recovered, you may have lost capacity. And 15% of the athletes having cardiomyopathy, there have been not a lot, but there have been a few that have basically died because of the exercising. They didn't know they had cardiomyopathy, and they just basically die during an intense workout or game. It's not inconsequential. And these are young people. I mean, it's one thing to have somebody older like my age, 72, it's quite common that older people have been seen as the people who catch COVID, but that's been proven to not be the case. Now that schools are back in session, the incidence of younger people and young college athletes and younger folks getting it is really quite striking. Now, this is a specific kind of problem for kids. This is a multi-inflammatory system that it ends up being a syndrome that's in children. And this is not a small study. The CDC collected over 2,000 children that had this multi-system inflammatory process. 75% of them didn't have any initial symptom of COVID. They didn't know that they had been exposed in any fashion. And suddenly the multi-system inflammatory process kicks in. Most were admitted straight to ICU. 90% had multiple organ systems involved. Over a third had cardiogenic shock, and 75% had precipitously low blood pressure. So you can end up with very severe symptoms even in very young kids. So, and this is a disorder that ends up hitting kids specifically. Even when people have had no obvious local infection, they find small microscopic damage in the brain. This is an MRI of a brain stem with small lesions that are in it, with no direct infection at that location. So this is a more of a systemic effect of some sort. And this is something that was picked up again on an MRI. What we basically see in brain pathology, if there's a large vessel emboli, that's a stroke. And they do report strokes. ICU strokes are not unheard of. They're very common, but they're very severe. These are thrombotic CVAs, so they create ischemia. They plug a vessel. Downstream, you don't get sufficient oxygen or glucose, and you end up with cell death in the area, a stroke. And this is not the kind of a thrombotic stroke that responds well to TPA. The normal way you treat a stroke that's a thrombosis or an embolism stroke is to put a clot buster drug in. It doesn't seem to be doing its normal job. You can have a direct viral encephalopathy. I mentioned through the eyes or through the olfactory bulb. If you have a direct inflammation, a direct infection, you can see beta spindling in the area. But if the inflammatory process is seen, you also see slowing. So excess fast activity in the acute infected area, and then generalized slowing because of the encephalopathy, the swelling and edema. Small vessel embolic stuff happens as well. These are microemboli, not the large clot, basically, but microemboli. They'll plug a small enough vessel. It's not seen as a major vessel stroke. This is paraventricular white matter change in an MRI, small vessel, not large vessel, and it creates edema in the area. And you can have direct cortical edema too. We've talked about the hypoxia creating edema, or the cytokine storm causing edema. Edema causes ischemia, that funny word. And what the heck is ischemia? Insufficient blood flow. It's not enough oxygen, not enough glucose to support full function. You can still kind of exist in the area. It's not the same as a stroke. It's not a cessation of flow to the area. It's just a decreased capacity. If you demand a lot of function in an area that has ischemia, you may end up with hypoxia or anoxia in the area and have cell death. So you don't want to overtax an area that's got ischemia. Post-traumatic ischemia, the injury to the head that causes swelling and inflammation in the area, you can have post-traumatic ischemia. Again, you don't want to work that area too early because you can actually cause cell death in the area by making an ischemic area work too hard. In the EEG, we see ischemia as a mid-temporal sharp slow transient, which is a non-specific finding. Niedermeyer, he's long since passed, but he did a study with over 200 patients, and they drilled down on what was really going on with these non-specific findings in these patients. And over 80% of them had a vascular issue, and less than 20% had an irritative issue. It was almost all ischemic. So it's non-specific, could be irritative, could be ischemic, but it's almost always ischemic. If it's not ischemic, it's irritative. That's more like a not a fully formed spike focus, but hyperexcitable cortex, irritable cortex. But these non-specific findings are seen: migraine ischemia, post-traumatic ischemia. You can have local vascular change, like an AVM or an aneurysm that causes local blood flow changes. You can have ischemia due to that. You can actually have atherosclerotic plaque buildup in the intimal wall, changing blood flow and causing ischemia due to aging, not healthy aging, but aging. And you can also have inflammatory edema, where the area has swelled because of some inflammation causing edema, and the edema will cause the ischemia. So there's a lot of these non-specific vascular things that can be seen. Now, there's no medical agreement on what long hauler COVID brain is, but I'm going to propose to you that ischemia is what's causing the symptoms that people are experiencing. This is the paper by Niedermeyer from 1987 that I basically quote the findings of. Again, you'll get this PowerPoint. So um, this is an interesting little piece. This is actually from the American Academy of Neurology. This is an old position paper that's been refuted. It's no longer anything other than a historic document. So its position against traumatic brain injury, use of QEG and things like that aren't valid. This document isn't valid for that. However, in the document back in 1997, they basically talk about cerebrovascular disease. And you tell me if this sounds negative or against QEG. EG frequency parameters highly correlated with regional blood flow or metabolism. There's their caveat: when used by somebody who's experienced, sensitivity and specificities are high for detection of ischemia-related cerebral impairment or other focal impairments. Studies show sensitivity greater than 80%, good specificities, false positive rates are low, correlations are high between EG and blood flow. Get this, many were controlled, well-designed studies. Some were prospective and blinded. And they showed that the QEG could detect reliable focal features that were missed on the initial review of the EEG. Get that, the QEG was better than the initial review of the EEG. It showed the problem clearly when it wasn't seen by everybody in the raw EEG. Now, I might suggest that somebody with a better eye may catch something in the raw EEG, but the QEG does really help see it, and you'll see that when I show some EEGs in a little bit. The QEG can be quite abnormal even when the CT is still normal, like right after a head injury or a stroke, when the degree of ischemia is mild enough to cause a dysfunction but without an infarct. Now, they go on to say it's not as specifically, focused structurally as a CT or MRI, but they're actually quite positive about the use of EEG and QEG for detecting ischemic change in the brain. And this is an old position paper. This is newer, not Mark newer, but newer, like more current. This is from 2012. This is a critical care medicine review paper, and they're looking at the use of QEG for detection of ischemia. They're basically looking at people that are in the hospital, in ICU, in a critical care circumstance, and they say that the use of the EEG, QEG is very helpful for detecting ischemia and to track the treatment of ischemia, and they're very positive about it. This whole paper, the entire paper, is included in the handouts that I've provided, and along with the EEGs that are going to be presented as well. So this is perfusion, hyperperfusion, hypoperfusion, and EEG frequency. And you can see the hypoperfusion is in the theta and alpha band up to about 10, 11 hertz, at which point it goes into the neutral positive perfusion up to about 16, and then it takes off into hyperperfusion. Linked ears doesn't track local perfusion, but Laplacian techniques do. And again, we need to remember this neutral positive perfusion from about 11 to about 16, because that's going to come in handy when we're thinking about treating people that have the long COVID symptom. So we'll keep this in mind. Again, this is the mean perfusion, significance 2 and 3 standard deviations of hyperperfusion, the mean significance 2 and 3 standard deviations of hypoperfusion. Now, it's not the faster you are, the more perfusion you have, because delta is also increased perfusion. When you're sleeping and you're actually producing real delta, not just some subtle slow thing that's a pulse or something, the actual delta activity, which is large, 50 microvolts, 75 microvolts very commonly, delta during sleep, slow wave sleep. Your brain is busy. You're not awake, but your brain is busy. Metabolically, it's really quite active, and with perfusion, it's really quite active. So don't think, the slower you are, the less perfusion, because delta is an increased perfusion as well. But the theta and alpha band, hypoperfusion, about 10, 11, up to about 16, this neutral, very nice, just above the mean, just about over significance, but not at hyperperfusion itself, just above the mean. So here's a case that had a working memory issue, and working memory is usually a frontal verbal working memory, and you can see the slow activity here. This starts out just outside the line, ends up on the line. Some of these take close, 5-6 hertz. Some of this is really quite slow. If you look at the spectra of that, in the back of the head, there's some frequencies that are up into the alpha band, but the F7 location where that slow edge of alpha showed itself, you can see the peak up there is at 8 hertz, but that's the peak. The frequency band here dips into the slower frequencies, trickling into the theta band. But we're going to look at this in more detail. I want you to remember this graphic, because this graphic ends up telling the tale of what we need to do to fix this. I'm going to stop this screen share, and I'm going to use a different kind of screen share to do some very bad art. I'm not an artist. We've got a blood vessel. I'm going to draw a kink in the hose to represent an area that's got some ischemia. So it can't flow through here. We've got a certain amount of blood flow here. We have less of it on this side because of the ischemic decrease in flow, or the availability of flow. But there's still some, as long as we don't overdo it, we can get this much supply. So if we create a very small demand, we can basically create the normal regulation of blood flow. If your brain becomes active, the brain will try to supply more blood flow to that area. It'll try to open up the ischemia. So if we make a small demand, it will try to open this up, and across time, it will. Like the root on the sidewalk, it will lift the sidewalk and crack it. Now, it's going to take some time. It's going to take time to open this up, but it works, and I can show you positive outcome over a short period of time with neurofeedback. So what happens if we make too big a demand? Well, if we can't supply that demand because of the impaired flow, if there's a too big a demand, then the perfusion pressure of oxygen, the PO2, drops. Low PO2 creates ischemia. That creates edema. Edema creates pressure. Pressure is going to make the ischemia worse. So if we make too big a demand, we can actually create a worsening of the ischemia. If we keep up the demand, we can have cell death, glutamate cascade and cell death from hypoxia. So, we've got to be careful with how much request for perfusion we create. So remember that nice neutral 11, 12, 13, 14, 15, 16 hertz, that little tiny bump in the spectra in the perfusion curve? Well, we need to keep ourselves at the low end. We need to be in that range. We can't do beta training. We can't do fast training. We want to gently activate this area. And that model is basically what tells us that we need to try that frequency somewhere between 11 and 16, preferably at the slower end of that. Again, we don't know how bad this is, so we have to be fairly conservative on what we're doing. We want to start gently, shorter periods, making sure that the person has a positive experience, doesn't end up with a migraine headache-like syndrome. The worsening of the ischemia can be experienced as a migraine or a headache. So keep this in mind. Now, let me get rid of the bad art, and let me go back to screen sharing, and I'm going to pop up the talk. Now, I've gone through the PowerPoint. This is the paper that I showed, so you're going to get the full paper. You can read it. It's got a lot of detail, but we've only got so much time, and I like to look at wiggly lines. So let's take a look at what we have. To start with, this is somebody who's got a brain fog. Brain fog being, he's 56 years old. He's been a medical tech, X-ray person for a long time, pretty sharp. But when you talk to him, he just couldn't understand what you were saying. And
sorry, Jay, I can't see anything. The video is not there. I don't know if it's only me.
do you see my?
No, you haven't. There's nothing on there, Jay. It's just
sorry, you've just got your whiteboard up still.
Okay, let me stop share.
I thought it was an artistic representation.
Okay, I'm sorry. I clicked on the wrong window to share. That's all. So, so this is a 56-year-old guy, and this is his EEG, and he's no fool. But he's not able to understand what people are saying to him. You've got to repeat it a couple of times for him to get it. So he's got a brain fog, essentially a receptive dysphagia of some sort. And as you look at his EEG, this is eyes open. And ask a doctor to look at this. Is this eyes open or eyes closed? Well, there's a lot of alpha. It's probably eyes closed. It's this guy's brain fog and his eyes open condition. And in his eyes open condition, he has some moments where his alpha's better. This is a pretty good frequency. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Just about hit the number 10 on the nose here. Start a little inside, ended at 10. But there's some of it that's a little slower. Some of these waveforms get a little slower than the 10 hertz. And as such, you'll see some of these as having a slower rhythm. A cycle and a half is 8 hertz. And some of these look like they're slipping below the traditional alpha definition. So, this is already cleaned up with ICA. We've taken the eye blinks out. We've marked a few moments where there was subtle movement and artifacts that need to be extracted. But this is ready to be tossed into the Fourier, and we can look at the spectra. And again, some of this, quote, alpha, this background rhythm, resting state background rhythm, doesn't really fit the traditional definition. 1, 2, 3, 4, 5, 6, 7. It's running a bit slow. So we're going to end up putting this through the Fourier. How do you get mid-temporal sharp slow transients? You blend frequencies. A slow edge of alpha with an alpha will get you a pretty good double peak. And again, it's cleaned up a little bit of muscle. You can see this, the front of the head, the back of that, there's alpha everywhere. And in the left posterior temporal area, which is where receptive dysphagia would be, the Wernicke area, here we are, 1, 2, 3, 4, 5, 6, 7. Not so good. And so we've got an EEG, again, cleaned up sufficiently. We can run this through the Fourier, but we can expect where we see these sharp, slow irregularities that there's likely an irritative or ischemic process in that area. So we're just going to take this and put it straight through the Fourier, the full file, 4-second long epochs. That'll give us quarter hertz resolution. And we can see the EEG. I'm going to give you the standard band ranges. Yellow is alpha. Notice something that's sticking up outside the alpha band. I don't think we need any database to tell us this isn't right. We've got a peak at T5, T6 at 7 hertz. And this is not where we would expect to see, a 7 hertz peak in somebody who was a normal functioning individual. This is an area that would give you receptive language problems. Now, he didn't complain about being prosodically dumbed down, but he probably is. And at this point, the slow edge of alpha, which tracks ischemia, is sitting right here in front of us. Don't you see that as a target? Now, if you did CZ to P7 as a montage and trained SMR frequencies, you can call it SMR here, but if you call it SMR here, Barry will hunt you down and I will help him. So, you know, it's SMR-like, but it's basically a neutral positive perfusion frequency. Call it an SMR-like training. It's SMR here, but it's not here. Again, it's neutral positive perfusion training, and it's going to take some time. Now, the training is done eyes open. Let's also look at eyes closed for the same case. Let me close this so we don't get the spectrum files goofed up here. And we're going to open the eyes closed in the same brain fog case. 56 years old. Again, this is the eyes closed. You know, is it different than the eyes open? A little bit. You know, one of the things I see, look at the waveforms up in the front here. Now, we're in an average reference, but it's supposed to show local function very accurately. Look at FP1 and FP2. FP1 and FP2 are virtually identical. The phase relationship between them in the alpha band is extremely high because their phase is extremely stable. The same waveform almost disappears at F3, FZ. And every time you see alpha, the peaks line up front. In the back, sometimes the peaks don't line up so well. There's phase shift going on back here. Up front, it's all phase lock. There's no shifting of phase. So the frontal lobe is basically sitting there relatively idle. The coherence is going to be high because you can see it's high. Now, these are moments of alpha dropout, and these are interpretable in the vigilance model as moments where alpha drops out associated with B1, a drowsy state. But you know, he's hanging in there. His alpha pops right back. We're not slipping into a long run of stage 1 where alpha is gone, and we haven't flipped into a theta state. But you know, it's looking a bit iffy here with respect to holding on to the alpha. It's sputtering, and we've got a distinct dropout. So he's got some vigilance regulation issues, and the frontal lobe is sitting there totally idled. We still see the irregular content at P7. We can run this all the way through. You can see this is cleaned up. There's very few moments that even need to be clipped out. There's, you know, this is the scalp muscle, the jaw muscle, the neck muscle that turns the head from left to right, the forehead. You know, there's a moment, goodness knows, he might have swallowed or something, but a moment of EMG, it's clipped out because it's not, you know, clean EEG to analyze. The EEG without the eye movements in it is just boring. There's a little flat spot at the very end that's clipped out as well, but you know, this EEG spectra can be analyzed. It's clean, full file, 4 seconds. Again, good resolution. Look at the double peaks. This isn't right at all. And why would he have a complaint of having difficulty comprehending? Because his Wernicke area's got this slow peak there. There's undoubtedly localized ischemia that's happened because of his COVID. We actually had a pre-COVID EEG, but and this wasn't present. We've got a short presentation. I've got a couple other cases. I'm not going to do this one fully, but we're going to show following training the CZ to the left temporal. What did this do? You can also see up front, slow alpha peak up front all over up there. The frontal lobe that regulates attention and affect is sitting there. Here's the raw coherence value. Any raw coherence value above 0.5 is considered hypercoherent. What do you do with the rule of thumb? You cut the thumb off. You know, use the database to tell you how far off it is. But if it's above 0.5, it's elevated. And this is at a 0.6 something because it maps at 0.7. So the alpha that we saw up front that looked elevated is in fact an elevated coherence as well. So affect regulation, attention regulation is not so good. And he's definitely got the COVID brain deficit over here in function. We're going to leave this spectra up, and I'm going to try to open the post long haul COVID, post treated, and we'll see if this opens without crashing. There it is. So you can see this is not accepted because there's a pulse artifact here, and whoever did the recording ended up with the fix at this point. So we're basically looking from that point on. This is cut out with the mark artifact. If it's underlined in blue, it won't be part of the analysis. So as you can see, we're basically looking at kind of awake and drowsing EEG. This is a DC hit. Again, artifact that's taken out along with some slow sway. But it's similarly cleaned up in a quite similar level of state regulation, little moments of alpha sputtering out. You can see the widespread alpha. It looks visually kind of similar. Is there really a difference between the two? Did the period of treatment end up helping, or was this just a theoretical thing and it was a waste of training time? So let's toss this equivalent data through the spectrum analyzer, full file, 4 seconds. Notice a difference? Where's that peak? Where's that peak that's in the red up front? Where's the peak? Well, the peak is kind of tucked up into the alpha band a bit. There's still a little reflection of it there. But it's slipped up into the alpha band. Now, if you don't remember the last one perfectly, I'm 72. I don't have any short-term memory, do I? Of course I do, but don't rely on it. You got to have a quantitative comparison. So let's compare. The second one we did was the most current. It was on 5/21. On 4/16 was the pre. So over a short period of time, this is the result. We're going to take the most current minus the prior, and the data is compatible with filters and montage and everything, or it wouldn't let us compare it. It won't let you make that kind of a mistake. So there's a decrease in that specific frequency here and here, and frontally a little bit as well. Again, filled by band ranges, so you get this is just outside the alpha band. We actually have a bit more alpha than there was, but there's less slow content below the alpha band. And that improvement in neurocognitive function was experienced by him as well. He felt back. He felt okay again. And again, there's more alpha than there was, and there's less slow alpha than there was. And up front, there's less slow alpha up front as well. So was the crazy idea of trying SMR type training to help with the perfusion something that seemed to work, and in a relatively short period of time? Yes. Does this represent everybody's long hauler COVID? No. This person's ischemia was here. The next person's ischemia could be more just purely frontal or more cingulate. You could have somebody with a motivational or obsessive compulsive thing that suddenly changed. You could have some affective regulation that changes. So this is where it was in this person with the complaint of essentially not being able to comprehend. His brain fog was a receptive dysphagia. And in this case, this is the network that we needed to work on. But the next person, in fact, the little brief sample I showed with just the waveform and the simple spectra was an F7, and that's working memory, verbal working memory. So one person may be here, one person may be here. Somebody may have a change in impulsivity or explosivity, affective gating, some dramatic change in prosodic perception. Again, obsessive compulsive. So where it happens, what network it happens to is going to determine what symptom it presents like. And our ability to describe accurately what's going on inside of our head with a symptom complaint is just terrible. Look at the DSM. It's everybody's symptomatic complaint that doesn't predict a damn thing. So, we've got to listen to their verbal presentation of what their complaint is, and that might suggest one of the networks to us, but you've got to look. Again, don't trust verbal output to describe what's going on inside the brain. If they have a complaint of neurocognitive function of some sort, you should look. Now, this is essentially just one case, but it was a rather easy illustration. I did this talk here in the US not that long ago, and when I started the talk, one of the people in the audience offered me a case. You trust but verify, you can cherry pick a case and illustrate almost anything. So, trust that I didn't just fake this, but let's verify it by looking at another case. Here's somebody who has a long COVID complaint. My apologies. I tried to import it as an EDF. It was a .eg file, open file, and long COVID case handed to me from Saul. Now, Saul wasn't being hostile. He was just double checking, So this is a global average montage. What looks like it's almost synchronized is in fact at the same moment, but it's out of phase front to back. It should add up basically to a 0. So having some plus, some minus ends up being correct. The first thing to look for is, do you violate Gauss's law of electricity? And this does not violate that. And as we scroll through, we basically end up seeing the EEG data set. It's cleaned up. Little alpha sputtered out. Just a brief moment there. We have some beta spindling at CZ. CZ beta spindling is generally going to give you an insomnia. And they're making it through the EEG here reasonably well. Remember, as we look at the spectra, that the beta is present at CZ. You can see the small spindles of faster activity here. And they're not really present in a lot of other spots. CZ has a beta spindle. That's a normal insomnia marker. And if you have insomnia, you have lots of drowsy alpha dropout points, and the alpha up front is exaggerated because of drowsing. But this is the individual's eyes closed. We just went to eyes open. We can analyze just the eyes closed and look at that. Again, it's all cleaned up. We can look at the eyes open as well. You can see with the eyes open, the background alpha is essentially blocked. Fast alpha sputters out, slower alpha. It's eyes open, but the signs of drowsiness are there, slow alpha intruding. And where does the slow alpha kind of reside? CZ, FZ, and again, the cycle and a half is about 8. And the slow edge of alpha is what usually is going to catch the ischemic issue. So we're going to look at it with the eyes closed, but with the eyes open, the beta spindle at CZ and the alpha distributions are visible as well. So we're going to go to the analysis, and the analysis on this is going to be of a fragment. We had the eyes closed fragment. Notice the slow edge of alpha. Got a little bit over here, prosodic perception, social perception, social anxiety, PTSD type of a feature, but the slow edge of alpha here. But a distinct slow edge of alpha at the frontal central midline overlying the cingulate. And don't you know, this is a presentation of an obsessive compulsive variety. So not language comprehension, not working memory, not social gating, obsessive compulsive trait, and again, social perception. So, this basically was a blinded rating, and this matched up with a symptom presentation. Again, social perception and obsessive compulsive. Now, OCD is the cingulate gives you cognitive or emotional flexibility. So when it's not working, whatever it's not working with, fast, slow, doesn't matter. When it's not working, the spectral deviation there basically is associated with the disturbance of obsessive compulsive, but it's also oppositional defiant. It's also procrastination. It's also lack of initiation, lack of motivation. If you're locked on, you have an OCD. If you're locked off, again, it's flexibility, and you could be locked on or off. If you're locked off, it's lack of motivation. The logical extreme to that is akinetic mutism, again, a cingulate issue. And procrastination is not quite akinetic mutism, but they're close cousins. So lack of initiation, lack of motivation, and that's also here locked off. So we've got an excess of alpha there, but the real deviation is the slow edge of alpha, which is likely the post-COVID worsening of the obsessive compulsive and social perceptual. So again, kind of alive as part of that presentation, and it validates with somebody else's data, not picked by me, that the slow edge of alpha. Again, depending upon the symptom presentation, you're going to find it in a different network that matched up beautifully with this person's complaint. Now, you might think, it's a roll of the dice, and sometimes you're just lucky, So let's see another one. We've got somebody who's 45 years old, and they're post-COVID brain fog, and a depression has also set in. So we'll look at this one. We've got an eyes open to look at first here, and it looks like it's crashed out the software. I'm going to have to pop it open again. 45-year-old, eyes open. So eyes are open. We don't have gigantic organized alpha that's ongoing. We do see beta spindles at CZ, again, an insomnia type marker. There's a cycle and a half. It's a little on the slow side. There's some alpha coming out of the frontotemporal areas here. We'll end up having to take a look at this, but you can see that some of these waves are outside the alpha band. That a cycle and a half doesn't quite fit. It starts out outside and ends up on the line. Some of these are into the theta frequency band, but it's this person's background rhythm. It's just pathologically slowed. Now, we've got left frontal, left temporal, left posterior temporal. Let's pull the F7 down and look at that. We're sharing that same wave. And you can see it's all the way down to here with that same wave as well. So this wave is a slow edge of alpha on the left frontotemporal area. And quite often people think of alpha on the left frontal area as a depressive presentation, but it's not all of depression. Dirk de Ridder is a fairly famous neurosurgeon, an old friend, and obviously he's presented to you at your society as well. And in his work, he's identified the anterior cingulate as a feature that's disturbed in depression. And he sees cross-frequency coupled data there. And I think you can see the beta spindle at CZ. If you can't see that, see your optometrist. The EEG here has all the hallmarks of some excessively slow content, but we also see some intermixed fast activity there. There's some beta coming out of the same area at the frontal midline here. So as we scroll through this eyes open EEG, the alpha is coming out of areas that you don't normally expect it to. We've got some normal alpha coming out of the back of the head. We've got slowed thalamocortical rhythmicity coming out of the frontotemporal area, again, worse on the left. So in the eyes open condition, full file, 4 seconds, just tossing this whole EEG through the Fourier. You should be able to see those peaks are sticking up over there. We've got slow edge of alpha. So is the alpha here, which is 0.369. Is this bigger? 0.526. I think we've got an asymmetry here to here. Again, a subtle asymmetry. We can map asymmetries, move this to a 50% asymmetric. You can see there's slow content and theta frequencies here and some alpha frequencies here. There's an asymmetry here. Now, frontally, there's actually some over on the right, but this intensity here. And this asymmetry, well, what's with the midline? It's always green. Well, this is left-right asymmetry. You never see anything at the midline. So don't blind yourself by only looking at symmetry. We have to look at the midline too. So the slow alpha over here is probably somewhat symptomatic, but I think we've got ourselves the slow intensity. There's a kind of a separate peak to this, and the slower content in the temporal area is kind of the down slope of alpha, but this has got a bit of a hump to it, doesn't it? And if you turn this up, notice the beta spindles that we start to notice that are present in the EEG, and there's beta content up front. So the slow edge of alpha and some fast activity are actually happening together at the frontal midline. But you can hypothesize that might be coming from the cingulate, but it's also good to be able to kind of look at it. So we're going to also look at the eyes closed and look at the spectra from that. Obviously, eyes closed is the other file. So while we've got this one available as a spectra, again, remember this area, but the frontal midline with the slow edge of alpha. We're going to open up the other file. 45 years old, eyes closed. So eyes are closed. Remember, the beta spindle at the vertex is something that gives you insomnia. So staying wide awake isn't the strength necessarily in this case. You can see alpha dropouts. Slow edge of alpha with beta spindling happening. The thalamocortical dysrhythmia is a coupling between the fast and the slow. Now, if you do an ICA of the data, it'll separate things into separate components. And, that's, if ICA wasn't neuroscience, it'd be magic. I mean, it really separates things out in a way that is extraordinarily helpful. But, it's hard to explain necessarily to anybody. But, let's say we set up a rave, but there was no band at the rave, just lots of people. And we handed out headsets that some of them would have a different song than others. If you see people jumping up, down together, they've got a temporal pattern that would identify them as a separate group. And really, that's kind of what we're looking at here. We've got some brain areas that are dancing to a different drummer, and they're going to be separated from those that are dancing to a different tune. So the cross-frequency coupling should separate itself really well, especially with the ICA. But you can see it. I mean, if it takes an algorithm to show me something, I got to wonder about it. But you can see the coupling between the slow alpha and the fast activity within the EEG here. So, it's likely real when you can actually see it right in front of you like that. So let's take what we have and run this through the Fourier and look at the spectra of this cleaned up file. We've got a prosodic perceptual feature, likely a PTSD. Now, if you've just spent some time in ICU and stared the Grim Reaper in the face for a few weeks, you could come out with a little medical PTSD. We usually see this sticking up in PTSD. I'm going to fill this by traditional band range colors. Notice that the alpha band in the yellow isn't really what we see here. This is slow edge of alpha here and here. It's widespread. I want to point again, not just to the slow edge, but to the hump. The ones we saw had bumps or humps, not just a slow edge. Now, this is still the slow edge. It's got more content at that frequency. And where's it coming from? Well, you can see it across the front. You can see a little bit at the midline here. This is likely the anterior cingulate, which Dirk shows as the source within his thalamocortical dysrhythmia, which is a coupling between the slow alpha that slows down to about 6 hertz. This is 5.86. We got to talk between Dirk and I about his theory, because he's a quarter of a hertz off here, or this patient is, and we're likely coupled with the faster activity that's in the EEG as a feature. Now, we're going to close this window out, but let's map some things just to get some pretty pictures. Yeah, sloppy in my pick. There we go. So the big peak here is just a hair outside the alpha band, and it's in the kind of the distribution at the back of the head that we usually see with like a migraine. Posterior temporal parietal junctions. There's actually normal alpha at the back of the head. Not big, but that's where it is. And you can see the slow edge of alpha there and there. Slow edge alpha's got this little island up front as well. Let's go up and look at it. That's the slow edge of alpha, but there's this as well. If we map that, you can see this little bullseye. Now the slow edge of alpha trickled down to that same frequency back here. If we look for the source of something based on the frequency, we're going to be distracted by all this slow alpha here, as this is a separate entity up here. So, you know, let's see if we can look at the rave of people jumping up and down here and see who's jumping up and down together by looking at the independent component analysis of the EEG itself. Not to clean it up, but just to look for who's jumping up and down. Now, there's 19 components. You're limited to the number of channels you've got for the number of components. You can have more components that you got electrodes. But the top 12 components are over 90% of the EEG variability. And we can speed up the calculation. This is Infomax. Infomax is a little slower than fast ICA, which is what was used for the ICA cleanup. If you do ICA cleanup with WinEEG, it's fairly quick, but it's using fast ICA, which is not quite as precise. So when we're analyzing it for separate components, we like to use Infomax or Amica. If you're using EEG Lab, Amica is a little bit better at identifying and pulling out muscle than Infomax is. But they primarily differ in the ability to identify muscle sources. So Infomax is awfully good, and it's what's been used in the WinEEG for all these years. So you can see it's not fast, it's just ICA. So, and ICA is different than principal component. Principal component's a great way to identify the components in a normative distribution, a Gaussian distribution. And although there are some people that would argue that EEG is Gaussian, it's still an argument, and nobody would argue that electrode artifacts are normal in their distribution. So ICA has been used quite effectively in the de-artifacting because it's very good at seeing independent generators. Now, my apologies for the time that Infomax takes, but it takes the time it takes. You can't boss it around and tell it to speed up. You can shorten the time by picking fewer pieces, fewer
there are
components.
a couple of questions in the chat if you
Okay.
want to take a moment to address those, Jay. Kerry's asking.
Okay. So we've got, do you ever see post-good peripheral muscle damage? Now, I'm an EEG person. I know that there are people that end up having all sorts of locations in the body that end up having damage from it, but I'm not somebody that knows muscle. They basically suggest that that they see muscle changes similar to corona. What's the vaccine history of this patient? In fact, these patients ended up with COVID without vaccination. There are people that have vaccination that have inflammatory immune reactions that can have the post-COVID symptoms from the vaccine. It's very rare, but that can happen. Again, the vaccine is intended to trigger your immune system to replicate your immunity towards the spike protein, and just that in and of itself can trigger an immune reaction in some people that end up causing the same kind of a problem. The spike protein, the ischemia is actually caused by your body's reaction to it more than the spike protein itself. The inflammation that happens is your body's reaction to it. It's your immune system attacking it, gets you in the middle. And there's very rare difficulties post-vaccination, but they do occur. There's a lot more problems if you catch COVID than the vaccine. And you know, here it's finished. Do I know the effect of graphene oxide on the microvascular network? No, I don't. With a sleep disturbance and spindling beta at CZ, can you also see vertex sharp waves of sleep? If the sleep disturbance is extreme, vertex waves can happen out of place, and with a very severe sleep disorder, you may find them with eyes open. It's extremely rare. Extremely rare. They have to have such severe sleep disorder that they're literally falling asleep on their feet. Their eyes are open. Their brain actually dips into a stage 2 state, which normally drops muscle tension. The vertex sharp wave is the response of the brain to a sound or a stimulus of some sort. If you have a good sleep spindle, you keep dozing off. But if they have beta spindling at CZ, vertex wave will typically reawaken them. So anyway, I think I sent a note back to Harry, but it didn't get clicked on send. Hey, Harry, good to see you too. Can you have vertex waves at FC? Basically, vertex waves are detected at CZ. Their distribution can vary. A frontocentral distribution for them is not unusual, but it's at the vertex. Anyway, let's jump over and look at the components that we've got. Here's an alpha. It's more left than right, but you know, when you look at these, what you see is polarity. The component has these frequencies. It's not just 1 hertz or 2 hertz or 10 hertz or some specific frequency. It's these rhythms combined. So it's an alpha and a smaller a bit of a frequency as well. And this one is 24%, almost a quarter of the EG variability is predicted by this component. Now, it's out of phase front to back. And, you know, the hospitologist might think of the red as a source, but the other people would look at the dark spot and go, oh, that's the dark hole of the origin or something. But it's polarity. A source analyst will look at this kind of like a magnet. A magnet has a north and a south pole on it, and if you put it on iron filings, you get big fields out of the ends. Well, you're looking at red over here, and you're looking at black or blue over here, but it's not coming from here. It's not coming from here. It's coming from the damn magnet. So when you're looking at these, don't be a hospitalogist thinking of these as the spot. You have to look. Looking with Loretta is better than guessing. So let's kick Loretta's in gear and see what it shows us. So we have alpha generated in the cuneus precuneus back of the head, kind of a normal alpha generator. The problem with this is that it's jumped to absolute extreme. Loretta is a low resolution solution, and they've just focused it to the hot spot. Now, the hot spot might be an interesting spot, but the entire distribution may also be. So let's get back the low resolution solution. What other areas are involved in this? We're not trying to go crazy and light everything up. We're just seeing, is there a secondary or tertiary location here? And we've got alpha in the back of the head and some on the left side. It's out of phase front to back. We saw that in the raw EEG when we were looking at it, but the sources here are posterior alpha generator sources. That's not our anterior cingulate feature. Remember the anterior cingulate feature had kind of a slow bump on it? Looky, we've got something with a slow peak at about 6, actually 5 point something. And hot to cold, this looks like it might be coming off the front there. Never know. my goodness, we've got ourselves a cingulate source. But again, jump to absolute extreme, trust but verify. We want to see the low resolution solution, not just what's the hottest hotspot. And it pretty much stays the anterior cingulate, but it's not just the cognitive division. It wraps around and it has rostral, some subgenual as well. So if you've seen Dirk's paper, and if you haven't, you should. I mean, how many neurosurgeons are friendly to neurofeedback? So, do him a favor and stay current with his work. He basically shows that in reward deficiency syndrome and depression, and reward deficiency includes like addiction and food addiction, anorexia, those kind of things have the cognitive division and the affective division involved in a thalamocortical dysrhythmia. Now, do we have a dysrhythmia here? Well, it's that slow stuff, but there's fast stuff in this too. Let me be able to bump up the graph size here. It now is able to be scaled up and down. You can see the fast activity that goes up into the mid-20s. Remember the CZ beta? This is our CZ beta source. It's a different source than the frontal cingulate source. And again, when you goose this over, we're not finding anything other than basically somatosensory, somatomotor, hyperexcitable cortex. And so the individual sources can be identified. And the frontal midline is there. This looks very, very similar, doesn't it? And it's got a little skew. It's not exactly the same. It's got actually some slightly faster frequencies than just this, but they didn't dance exactly the same. So they're being pulled apart as two separate groups, one with 4+% and one with 3+%, almost 4. But they're very similar. This one is there. Let's look at this one. It's the hot spot here is on the right side, but the source is more on the left. How does that work? Well, let's do a little bit of really bad art again. You've got the midline, and you've got the cingulate on this side, and you've got the midline, and you got the cingulate on this side. They actually have some curvature to them. They're not just planar. And you've got the cortex going across. Well, if this projects off the, so if it projects over here, it kind of blends in, you don't see too much of it. But if the upper edge projects it, it might be seen on the right frontal from the left cingulate. If it's projected from here, it might be seen on the left. Now, if both cingulates are active, you see the blend of it across the front. But when you see an asymmetry, don't believe it's necessarily coming from the spot you see the hot spot on, because it could be projected from the contralateral cingulate because of, again, this curvature aspect to it, projecting perpendicular and actually hitting the frontal area of the contralateral hemisphere. So when we look at the source here, and you swear, God, that's got to be on the right side, and when you actually look, you catch this is more left than right. If you pick this on the right side, don't see nearly as much of it as you end up seeing on the left side. So there's a bit of a lateralization even there, but it's the anterior cingulate. Very similar. I think you could add those two together and have this little nuanced difference kind of blended in. This is a little bit more in the cognitive division, but when we scale it, we'll see what it does. Notice we get kind of an unwanted visitor. I'm going to try to cherry pick an insula into our vision here. And you can see this is still in the lateral aspect, the frontal, but it's kind of nibbling into the insula area. It's got a piece of the insula here. So it's not just the anterior cingulate, it actually has some of the insula involved. So it gives you a whole bunch of interesting potential targets. Autonomic disturbances, POTS. You've got vagal nerve access here. So some of the neurological source. So that's this one. Close the Loretta out, and again, you know, we jumped through a few sources. The last few sources get pretty spotty, but they're down to a single-digit percent, a couple percent. So they're not as strong a component. They still have some interesting material in them. This has alpha frequency and slow content, and again, seen centrally. Might have a touch of mu in one of these. But the EEG here has shown the depressive symptom to likely have an anterior cingulate source consistent with Dirk de Ritter's observations. Well, whoever M is here, could there be some right anterior insula also? I think there could. You know, we basically have we basically have evidence of that at this point. So anyway, we've got people asking about the vertex waves. We didn't really see them fall all the way asleep in this to demonstrate a vertex sharp wave. Yeah, it's a good thing to know what you're looking at when you're interested in seeing those. And although it has absolutely nothing to do with the topic at hand, I don't mind jumping out of my prepared talk and taking a look at a slightly different piece here. Let me close this out. I'm going to go in here.
Jay, I'll just take a moment to let you know you've got about 10 minutes, 12 minutes.
Maybe I should just stick on this as the topic and not jump into it. I'm awfully tempted to show drowsiness here. I can't help myself, you know. This is a particular EEG. This is in the global average montage. The one we've been looking at, eyes are in the front, occidentals at the bottom. And as we start to grow through, you know, it's eyes closed. We got all this alpha, the parietal area, alpha, the occipital area, and it starts to basically sputter a little bit with slower stuff happening. The vigilance model, or V3 with the theta happening, but they popped right back in and out of drowsing, but they're kind of losing the fight. They're slipping out of awake and into just plain drowsing. Now, this is all stage one. It's not stage two. Stage two is a vertex sharp wave, and ideally, if it's a K complex, it's followed by a spindle. But you can see the alpha is kind of going goodbye and the slower stuff is happening. This is a vertex wave. Some sleep labs may not call this. It's not that dramatic. Now, it's easy for us to see, but it's not that dramatic. Sleep lab is usually waiting for one to grab them by the tie and pull their nose to the paper, or now it's the screen. But you can see they're not awake now. They're deeply into stage one drowsing. As we scroll along, a very brief re-alerting, but they're right back into their drowsy condition. Now, this is 90 seconds in, a minute and a half, and they're not really awake. They're sputtering and very, very drowsy. You tell me when the vertex sharp wave hits. They're really quite dramatic. My goodness, a vertex sharp wave. Now you look at that and you say, God, Jay's lost it. It's not sharp, it's big and slow, you know. But a sleep lab doesn't use the same sweep speed. This is that same moment. That's why they call it a vertex sharp wave. There's another one here. There's another one here. You know, they're easy to spot. In a sleep lab, they have this kind of a sweep speed. The little buzz you see here is a little bit of background alpha that came back. A little buzz of alpha coming back, not much. You know, slow content that's in the EEG, but it's not a vertex sharp wave. Again, another vertex sharp wave here. So vertex waves happen as you are alerted by something. And if it doesn't wake you up all the way, you might have a sleep spindle that follows it. Let's see if we can find one that doesn't really wake them up. Well, here's one. Where's the alpha afterwards? Well, it's not really happening right away. The vertex wave is like here. Let's look at this period of time and see if there's a spindle of SMR. Here's where the vertex wave was, and you see the spindle. And the vertex sharp wave happened early in this. The spindle stabilized, and they stayed basically asleep. This is the spindling at about 12 hertz. So 12 to 14 hertz is a vertex wave is followed by a sleep spindle, which is 12 to 14 hertz. SMR's group average peak at 13 hertz. Pretty much the same thing, same generator. So I probably blabbed on through most of it. If somebody's got a direct question, please unmute yourself. I'm happy to bat ideas back and forth. You can even call me names if you want. I don't care. Whatever comes up. Everybody's still muted.
Hey, Jay, so I had a question, and so if we see theta at FZ, and at the same time we see something at F7 or at T3, which is kind of phase reversed, what do you make of that? Because I remember you said that F7 theta is working memory. So
yeah. Everybody's going to end up having their own distribution for what their symptoms present like, and it's usually an interesting mix of networks. The frontal midline is usually cingulate, and you should source it to the cingulate, not just assume what you see up front happens to be from the cingulate. You can have frontal alpha that's just a field effect from the thalamus, but you can have frontal alpha from an anterior cingulate source as well. And you can find the cingulate sources there. If you can't find a cingulate source, you probably have just a projection from the thalamus. Actually, Yuri Kropotov identified peoples that had frontal alpha that didn't have a frontal source. So, you know, at that point, you've got to kind of dismiss it as, yeah, it's real in the EEG, but there's no local generator. It's just a field effect. And you see that with gigantic coherence. If it's a giant field effect, your coherence goes above 0.8 as a raw value. And when you get that high, you have to start to look, is there really a source, or is this just a field effect? I've seen occasionally above 0.9, and I have very seldom found an actual source for that. It's just too identical. And so you have to look for the source analysis to know for sure. You can be fooled by the surface EEG. The generator you assume is right under your electrode, but it could be coming from a distant location and being picked up Not everything comes from right underneath the electrode, obviously. There are a lot of people who think that's the case. They'll put an electrode on a T4 and think that they're picking up the amygdala. And it's above the amygdala, but the amygdala is not really generating surface EEG. It doesn't have pyramidal cells. It's hooked to the hippocampus and the parahippocampal, which is the hippocampal cortex. So it has a representation in the temporal area that's further back. Again, it doesn't just pop up above where it's located. A lot of people make the mistake of kind of assuming, it's got to be right underneath, but the dynamics have to be looked at very carefully. The insula can end up generating a field that picks up the midline and a lateral finding at the same time. They're usually going to be out of phase. They're generated in the insula. It's picked up in one phase to one side and another phase to the other side. I don't have time to show you cases with it, but it's very common. You'll see F7T3 in phase and CZ out of phase. You probably got the insula. Sometimes you'll see an FZ, F7 out of phase with a little faint left temporal, and you'll localize that to the insula as well.
Thanks.
Sure.
We have time for just a couple of more questions before we take a lunch break.
You obviously need to fuel back up. I'm not having to bat anything back. You're not pitching here. So,
hi, Jay. I've got a question for you.
Thanks, Moshe. You're saving me here.
No, that's all good. You're saving us. That's there's a lot of work that's being done by Seaburn Fisher and folks working with trauma, working at O1 and O2 and at the Indian Ridge. And there's talk about picking up EEG that's coming either from the cerebellum, which you've talked about before, but also from PAG. Just your thoughts on what we might be picking up, because there are some very positive effects from work there.
Well, O1, O2 pick up a lot of things, including event-related potentials. The visual event-related potential is picked up there as lambda. So there's a lot of activity at the O1, O2 area that isn't just simple background alpha rhythm. Lambda waves actually are a theta frequency wavelet, but they tend to happen repetitively in PTSD, and Seaburn works with trauma very heavily. The excessive lambda in PTSD is actually well documented. Your local group STARTS actually did a project cleaned up the data on, I think, close to 250 people that had trauma, and STARTS has pretty irrefutable trauma cases. Horrible stories. You don't even want to listen to them, that traumatize you. So they actually found the right temporoparietal junction as a spot that differed that group. I know there are a lot of people that work at T4, P4 with trauma clients based on not QG guidance, but symptom directed. And symptom stuff has gotten us a long ways, even before QG happened for the neurofeedback world. But the PTSD subjects have the T6 or P8 location. If you look at a handful of PTSD cases, it'll tempt you to actually work more directly on the P8 or T6 location. I do like to use the modified nomenclature with P8. It's the temporoparietal junction on the parietal side. So the T6 electrode didn't really sit in the temporal lobe. They were fooling you since 1948. With the modified nomenclature corrected, it's actually located on the parietal side. But it does pick up the parahippocampal area very nicely. And as such, it does reflect the amygdala hippocampus complex. Now, the amygdala hippocampus for decades they were confused as to, amygdala being memory and the hippocampus being emotion. But when you stimulate one, you get the response from the other. It's like Siamese twins. When you kick one, the other one says, ouch. So they were confused in neuroscience for a long time, exactly what the roles were. They've differentiated them well enough now that the amygdala is more specifically an emotional processor and hippocampus more specifically a memory processor. Doesn't mean it doesn't process emotional memory. And they're so tightly intertwined they can't really be totally separated, and they're both reflected in the hippocampal cortex.
Is P8 also tapping into the posterior insula? I'm finding I work a lot with police with exposure to the grotesque, where their PTSD is predominantly driven by an affective response of disgust rather than fear. And that P8 site seems to be really
I've very
effective.
seldom seen the T6 or P8 location as directly sourced to the insula. It doesn't mean that it's not reflected in that network. The emotional processing includes affective gating, lateral frontally. The insula is directly involved in that, really quite strongly. Impulsivity, explosivity quite often is triggered with the insula. But usually the insula projects more to the anterior temporal and lateral frontal areas. I'm sure that the very posterior aspect of it may project posteriorly, but in a given case, you have to find that with your source localizing. Find a component and map the source of the component with Loretta. And again, on occasion, you may find it. It's not the commonality. Most of the insula stuff ends up being further forward. And it can end up presenting with some very interesting symptoms. An epileptiform discharge in the insula can end up having abdominal pain without any kind of a striate muscle convulsion. The discharge ends up having a spasm in your intestinal tract, which is represented in the Sylvian fissure and insula. So, and there's documented cases with what's called intestinal epilepsy or abdominal epilepsy. Those terms aren't part of the international classification systems. They're archaic terms, but they're very descriptive, and you'll still see them floating around in the literature. Again, it's a partial seizure, but again, if the abdominal pain responds to an anticonvulsant and you see a paroxysm coming out of the insula, you've got yourself an abdominal epilepsy case. That's not called that anymore.
Thanks.
So Jay, where do you find the epileptiform discharge in insula? So would you find it on, say, for example, F4, F8?
In fact, you usually see it more laterally, really horrid art. You've got the midline of the brain. You've got the frontal lobe coming over here. You've got the temporal lobe. And in here, you have the insula. So if the discharge comes from the insula in this location, it's a pyramidal cell with this orientation. It's going to project its way out. It'll be picked up at the T3 and the F7 or F7 T7, not so much the T5 or P7, but it's projected out and it's picked up here. So you'll see pretty good size voltage here, pretty good size voltage here. And the other side of it, the butt end of that projects out and it hits CZ. So you're going to see big waves at F7, T7, and a smaller wave out of phase at CZ. And when you see that pattern, this is where it's coming from. Now, the C3, you'd think, well, the C3 is sitting right there. Why the hell doesn't it show up there? And the waveforms are literally going to be up and up at those and down at the CZ. And, why doesn't it show up at C3, right in between? Well, it's a transverse projection. It's going back and forth, not coming out. And C3 picks up things that are being projected out of the brain up into that location, perpendicular. And the stuff that's going back and forth underneath it is invisible to it. That's the nature of EEG. So you'll see at F7, T7, again, with a pretty good size set of peaks, and out of phase at CZ, and nothing in between. And that pattern is something that you're going to be able to see in the EEG. Once you've had it pointed out to you a couple of times in the real thing, I mean, this is bad art. Don't go by this. Look at an EEG with it in it. Once you've had it pointed out a couple of times, it's fairly easy to spot and kind of extrapolate from the raw data that this is probably the insula. But you don't see it so much at the F3. If it's up at the upper edge of it here, you get it a little bit further forward. You might catch a little bit at FP1, but you see it on the side. And again, out of phase here, you might get a little bit there, but not generally at the F3. Usually it'll, again, because it's being broadcast laterally, you don't see it above it, you see it off to the sides.
Thanks. And how do you train for that?
Well, if you see it as a discharge in the temporal area really easily, that's an easy spot to catch it. And you just simply look at the spectral content of what's being projected out. Quite often it's a bit of a paroxysmal burst, and it's usually got slower content in it, maybe the slow edge of alpha mixed with some slow content theta, sometimes delta, but usually alpha and theta mix. I have yet to see it as a cross-frequency coupled prominent phenomenon. You can get beta spindles at CZ, but you don't necessarily see it coming out of the insula.
Oh, Jay, that is a thing of beauty. You need to autograph that. We'll take a screenshot and that'll be our next auction item.
Oh, God.
I've taken it.
Oh, look, I think we could take art
get rid of
classes.
it.
We could do EEG art as another therapeutic brand.
The last time you got $4,000 auctioning off my beard.
Oh, yeah.
And some damn fool bought that stuck on a wig the next year.
Yeah,
I can imagine that.
We still have that. We have your DNA captured, Jay. Look, we do need to give everybody a chance to refresh because we've got Lulim in the house and we'll be ready to speak in about 20 minutes. So I'm going to thank you so much on behalf of everybody. I mean, with or without direct effect of COVID, I think we've got I think a concern about survivor fatigue or COVID fatigue that is going to be globally impacting all of us. And watch that space. Thank you once again, Jay. Everyone.